That's it. Can you see the screen?
Yeah, Macha. Yeah, can see.
And then we can start with so this is a small topic. So this is a long case, and regarding the topic, we will be doing the ovarian tumor today. And this is an important topic in gender nurse because this is a common topic that is the mostly the questions will be asked on MCQ. Uh, Not common regarding the SEQ, but again, this is a common topic to be given in the short, long case. In the gynecology part, so we have to study it well, and this is an easy topic, and personally I got this topic for my long case. The discussion was so easy regarding this ovarian tumor and diagnosis. So just we will go through the slides. uh, if you have any doubt while I'm doing the that, just ask me, yeah? So I will clear the doubts at the moment. And
Okay,
so
Macha.
first, we will be having the overall idea regarding the ovarian tumor. So we can categorize in the ovarian tumor into several parts. So the main classification that we have to know these four: functional, inflammatory, metaplastic, and the neoplastic. So we have to know functional mean there is a due to the ovarian function there will be due to the function of the ovary there will be origin of the cyst or tumor. Here the ovarian tumor mean that is not like a mass. It's also they include the cyst. Cyst mean the cavity, the fluid filled cavity kind of thing. Cyst also they are including within the tumor. So it can be functional due to the usual normal regular function of the ovary, that comes under functional tumor. Give me 2 seconds. Okay. The next one is inflammatory. The name itself implies that due to the inflammations of the ovarian tissue, there will be origin of some kind of tumors. It may be kind of mass tumor or cystic kind of thing. So that is inflammatory. Metaplastic mean due to the change of the tissue within the ovary, the change into the metaplastic mean that is kind of a biological process. We know due to the metaplasia, there will be a change of the ovarian tissue that can cause metaplastic tumor. And the last one is the neoplastic that we call the original, what usually we study it as a tumor. It can be a benign one or malignant one. So these are the classification that we are going to look at, and we will be studying each and every one. And the most important one is the neoplastic one, because that will be asked usually in the MCQ, SBR, and the long case. But anyway, regarding the functional tumors, also they can ask some statements on the MCQ. But the most important thing is the neoplastic. Okay. We will be having some idea regarding the functional tumor. So if you want to call tumor as a functional tumor of the ovary, the diameter of the tumor should be more than 3 centimeter. Less than 3 centimeter, we doesn't consider it as a tumor. So it should be more than 3 centimeter. And usually, if you take the functional tumor, most of the girls may have functional tumor without any symptoms. So usually the girls do have the tumor, which are functional tumors, because due to the functional cycles of the ovary, there will be the origin of tumor, it will be there, but it doesn't show any symptoms, kind of pain, discomfort, or any kind of symptoms won't be there. So it will there and it will resolve. So majority is asymptomatic, and when there's a problem, due to the problem, sometimes they may present like it may be pain or discomfort, any kind of accident of the tumor, cystotumor, the patients may present. Otherwise, it may be accidental finding. Patient would have gone for some kind of investigation for any other problem, and accidentally they would find it, and no need to do anything. Just we can watch and see. So usually, rarely the patients present with the symptoms. The common presentation are asymptomatic and the accidental finding. The rare symptoms are: one is discomfort due to the size or due to the compression of the tumor due to the adjacent structure. Patients may feel pain or discomfort. That's the most common symptom if they develop the symptom. The next one is the acute abdomen due to the accident of the tumor. Like it can be torsion. Torsion means we know the torsion, hemorrhage. it can bleed into the tumor and the tumor can rupture. So ruptured tumor can cause for inflammation and severe pain. So these are the causes which lead to acute abdomen, and the patients will present immediately with a severe sharp pain. That is one kind of presentation. And the other one is a irregular period. Irregular period means usually the functional cyst or functional tumor doesn't affect the menstrual cycle of the woman. But some functional tumors, usually I have mentioned corpus luteal cyst, some functional tumors are hormone secreting tumors. For example, corpus luteal cyst. We know what is corpus luteum. After the ovulation, the remaining tissue will form cyst, which is called the corpus luteum. So it will secreting the progesterone hormone. Usually, if there is no fertilization, the corpus luteum will tail off and it will reabsorb into the circulation. But sometime in some girls, patient, the corpus luteum will be remaining and will be producing the hormone continuously, mainly the progesterone. So that if it do like that, there will be a problem due to that hormone. Due to the progesterone, there will be a problem with the menstrual cycle. So that can cause irregular period. So these kind of symptoms also can be there, but these symptoms are very, very rare. The common presentation are asymptomatic and accidental finding. Okay, is there any problem?
No, Macha, understood.
Okay. Then we will be looking at the next one, the inflammatory one. Okay. Inflammatory, we know that is purely due to the inflammation. These are the causes how ovarian inflammation can occur and it can form a cyst. So just go through this. Abortion, that is a known cause, and IUCD insertion due to the improper technique, it can cause inflammation. Tuberculosis, that is a one common condition, and purpura after the delivery of the baby. After the delivery of the baby, there can be inflammation of the ovary. So these are the causes. These are not only the causes, there are several causes. These are common causes that we can see. And no need to remember all the causes, because I am sure that they won't be asking questions regarding inflammatory cyst. So just for knowledge. And this is the most important one, the neoplastic ovarian tumor. This is the topic we have to consider and we have to study well. These are the common topic to be asked in the MCQ and to be given as a long case. So we can classify the neoplastic tumor into 4 groups mainly regarding the origin. One is epithelial origin, mean normal epithelial tissue of the ovary, that is surface epithelium. And the second one is a germ cell tumor, that is the tumor arising from the germ cell, mean primordial cells of the ovary. The third one is a sex cord, mean hormone secreting tumors. So hormone secreting tumor can be there in several categories. So neoplastic tumors also can be hormone secreting tumor that we call sex cord tumors. And the last one is a metastatic. Metastatic means the origin of the primary tumor origin will be there somewhere else, and it is metastatic to ovary. The common one we see is Krukenberg tumor. Usual origin is stomach, gastric origin, and it's metastasis. The metastasis usually occur due to the transcelomic spread, and it's come to the ovary. So we have to remember the name Krukenberg tumor. That is the example for the metastatic tumor. Other metastatic tumors are very, very rare. This is the most common one. Okay, understood that?
Krukenberg, from where it's come?
It usually come from the stomach.
Yeah,
that is the most common origin. So usually this is the most common metastatic tumor that we see in the ovary. Still there are other kind of tumors can metastasize rarely. Okay. Okay. The next one, the malignant tumor. Just I am explaining the features and the things regarding the tumor. Then we will move to the how to approach a patient with a long case. So malignant tumor feature, we have to know this feature. These are repeatedly these been asked in the MCQ, and if you have the case in the long case also, they will be questioning on these factors. What are the malignant tumor features we will be looking at? First one is age. The thing regarding the ovarian tumor, it can occur in the childhood and the elderly. Regarding the elderly, usually it is epithelial tumor. In the childhood, usually this is germ cell tumor. Because still the ovaries are getting developed, so there's high chance of development of the germ cell tumor compared to the epithelial tumor. But in the elderly people, the common kind of tumor is the epithelial tumor. Then the rapid growing. Usually the benign tumors, we know in most of the places the benign tumors grows more slowly. The same factor here. Benign tumors grows slowly and the malignant tumor grows rapidly. So if we observe a rapid growing of a tumor, that is more suggestive of a malignant one. Then the bilateral. When we compare other tumors, usually we see a unilateral tumor which can be a malignant one, but regarding the ovary, usually the malignant tumors are bilateral, not a unilateral one. We have to know that, because we may sometimes get confused. Usually these tumors are bilateral, the malignant tumors of the ovaries, that we have to know. Then the consistency of the tumor, if we take the consistency usually solid, nodular, irregular surface, then we have to think it as a malignant tumor. We have to have a suspiciousness. Otherwise, benign tumor won't be having these features mostly, not always. Usually these features are belong to the malignant tumor. So if we do, when we do the ultrasound scan, if we see nodularity, solid material and irregular surface, we have to further investigate. And we have to look whether this is malignant or not. So these features are suggestive toward malignant, not always toward malignancy. So we have to further investigate. That is the message we have to get it here. And the increased vascularity. Usually vascularity is highly increased in the malignant tumor. We know because due to the several growth factors secreted from the tumor cells, the vascularity automatically increases. So the same happened here. And we know when there is a malignant tumor, it grows rapidly and it is firmly attached to the surrounding structures. So that is also suggestive of malignant. We know also that inflammatory tumors also can get attached to the surrounding structure. That's why I already told these features are not 100% toward the malignant tumors, but if we find these features, we have to always think about the malignant tumor. And the edema of the leg and the venous obstruction, the same. Venous obstruction lead to edema and the varicose city of the legs, because when there is a malignant tumor grows rapidly, it goes and compresses the vena cava. So there will be a venous obstructions of the flow of the venous tract. So it will be accumulated in the leg. It can lead to edema, and lately it can also cause varicose vein. That is also other feature. And the last one, evidence of metastasis. Even still the ovarian tumors can metastasize to several organs, including brain, backbone, and spine, lungs. So if you also find those features, we have to think about the malignant. So these features you have to anyway remember. It can be asked still in the discussion and the MCQ. Okay? Any doubt?
No, I'm fine.
මචං අර මේ ඉඩීමා එක මොකද?
Edema mean when the usually these tumors are bilateral malignant tumors grow rapidly. So it grows so huge, and the size becomes so huge, and it compresses the inferior vena cava. So there is an obstruction to the venous flow. So it causes the leg edema and the varicose.
Thank you.
Okay. Then the epithelial tumor. So we already have we have talked about 4 type of tumors, including epithelial, germ cell, sex cord, and the metastatic tumor. Epithelial tumor is the most common one. Okay, usually it arises from the surface epithelium, and this is the most commonest ovarian tumor. We have to know that, because when there is a suspicion of malignant tumor, we have to think about the epithelial tumor anyway. Whatever the age, we have to think about the epithelial tumor. So that's what I have mentioned this. That's the commonest ovarian tumor. Then the second one, germ cell tumor. This is the second commonest one. I already told germ cell tumors mainly occurring in a young age group. Because when we compare, when we take the elderly, almost the development is fulfilled. So germ cell tumors are so rare. But we can't say that there's no more germ cell tumor in the elderly. Still it can occur, but very rare. This is more common in younger age group. Children. If you go to the gynecological ward, the children mean the adolescents may present with this germ cell tumor. So that is common. Second commonest one. And it contains benign and the malignant one. The common one is the benign one. That is the dermoid cyst. We would have heard about the dermoid cyst. Dermoid cyst consists of multiple tissue, including hair, bone, teeth particles, that kind of cyst. There will be a cyst containing multiple particles. So if we do the surgery and remove the cyst, it will contain not only the fluid, but also several components. There can be hair, bony particle, teeth particle, because that consists of developmental tissue, primordial tissue. So there will be several tissue. That is dermoid cyst. That is a benign one. That is the commonest one if you study the germ cell tumor. And also have malignant tumors also. That is rare compared to the benign tumor. And whenever we study about the germ cell tumor, we have to know about the tumor markers. But I think we no need to remember these tumor markers, because this is not common to be asked. Just know that there are tumor markers to be done on the germ cell tumor. The most important tumor marker we have to know is regarding the epithelial tumor. That is CA125. Regarding the epithelial tumor, the tumor marker is CA125. That we have to know. But just have an idea, there are also tumor markers regarding the germ cell tumor. Alpha fetoprotein, beta HCG, LDH, and inhibin A and B. Each of these tumor marker arises from different kind of tissue. I think we don't need. Actually, they won't be asked in anywhere in our exam paper. So no need to remember. Just know that there are tumor markers. These are the tumor markers. If you want to know, just remember it. Okay. I think, is there any question?
No, madam. No.
The next one is a sex cord tumor. Sex cord tumor means sex hormone secreting tumor. So if we know that in girls sex hormones can be divided into estrogen. There are several. The common one is estrogen, and also there can be androgen secreting tumor. Androgen means that is usually seen in high level in male. So if there is androgen secreting tumor, so there will be features of masculinization. So the girl will be having a features of boys, the thick boys. The hair distribution will be like a male one. So kind of features will be there if there is an androgen secreting tumor. That is we call masculinization, masculinizing features. If there is an estrogen secreting tumor, then they will be having a feminizing feature. Mean the female characters will be more heavier, like they will be having early menarche. And estrogen secreting tumor means it will be continuously secreting estrogen at the same level. So there won't be up and down, like cyclical changes of estrogen. There will be the estrogen at the same level. So in the absence of the cyclical secretion of estrogen, there will be no menstrual cycle. We know that for production of the menstrual cycle, there should be a cyclical change of estrogen. it should be going up, and after the menstruation, it should come down. So kind of change should be there. But when there's a tumor, the change won't be there. So there will be features of amenorrhea, mean the absence of menstrual cycle. So that is regarding the sex cord tumor. Then have you understood up to now? Then we will be moved to the long case.
Yeah, understood. Sachinder?
Oh, hello.
Okay. Then this is the part we have to study about how to approach a patient with the ovarian tumor. The thing is, sometimes the patient may know that they are having some kind of tumor. So some patient may tell that they are having ovarian tumor. That is regarding their presentation. Because it takes a long time to diagnose an ovarian tumor in our sector. Because the presentation is so vague. So they won't be having a typical presentation of ovarian tumor like perectal bleeding for the rectal CA. So here for the ovarian tumor, there won't be the typical feature to diagnose. So at the time of the diagnosis, the features will be something else. So if we see a patient like that, we have to think that this is a case of ovarian tumor. So we have to have that broad idea how to approach a patient with ovarian tumor. If we pick up that the patient is with the ovarian tumor, then the rest of the case is so easy. So I had this case for the ovarian tumor in my long case. The discussion was so easy. So how to approach a patient? That is the common. The history template is common, and we have to more consider on the history of presenting complaint and the presenting complaint. So first we will be taking the general information as normally, and we will be coming to the presenting complaint. This is the most important part because they won't be having a typical feature. Some patient will be telling the 3-month history of burning type of abdominal chest pain. The presentation is kind of gastric ulcer. And if you go through the history, there will be several doctors have seen the patient and has treated several times with the omeprazole kind of PPI. So that kind of history, the patients may tell. Now they would have diagnosed this ovarian tumor and they would have given to the long case. So that is kind of presentation. That is a common presentation. I think we have seen the Maharagama ward. Gastric ulcer kind of presentation. So we know that the gastric ulcer patient won't be given to our case. So it may be ovarian. And the patient may know some kind of information, kind of ultrasound scan, there was a tumor, kind of thing they may tell. The other presentation is abdominal distension. That is also some patients may present because this is a rapidly growing tumor. It is late diagnosed. Usually, it is diagnosed lately. So the patients may present with a large, huge mass. Usually, when we get a case of ovarian tumor, when you touch the abdomen, you will feel a mass. That is a common thing. My case also, there was a huge mass. There won't be doubtful mass. That is a absolute mass will be there in the abdomen. Usually, 99%. So abdominal distension will be a case. So if first one is if you take the abdominal distension, if you know, we know we have to go through some process to take the proper history. So you have to exclude some differential diagnosis if you find abdominal distension as a presenting complaint. So I have mentioned some causes. What are the causes for the abdominal distension? Ovarian cancer will be one. So that will be the diagnosis anyway. And you think about the uterine fibroid, bowel tumor, chronic urinary retention. So just take 3 and just exclude 3 differential diagnoses. That's more than enough. I don't want to tell about the uterine bowel tumor and chronic urinary retention. You would have already studied. So we will focus on the ovarian tumor, cancer, and just try to exclude other 3. Just asking by some question. And the problem is, the patient with the ovarian tumor can be elderly one. Sometimes it may be a young patient also. So don't get confused. Sometimes there may be a younger patient, and the history itself tell the presenting complaint will be vague, and they would have been investigated for a long time regarding the condition? If not, the patient will know the diagnosis and tell you that they are having a ovarian tumor. That may also happen. So that is easy peasy. So we can easily finish the history. So if you get the presenting complaint as a gastric ulcer kind of presentation, you just exclude gastric ulcer and any other kind of chest pain. So just exclude that and come to the diagnosis of ovarian cancer. I don't know whether you guys are thinking whether it's some difficult, but when you see that patient, 100% I'm sure that you will know that this is a case of ovarian cancer. So if you suspect ovarian cancer, what you can do is at the time of after thinking that it may be ovarian cancer, just palpate the abdomen. You will be seeing a mass. That is a way of make sure that this is a case of ovarian cancer. So if you just feel it, there's a mass, so we know that we can make sure that is an ovarian cancer case. Then we can move on with 100% confidence. So I just did that because I got an idea ovarian cancer. The Archie presented with the several presentation. So I just palpate and there was a tumor. Then I thought about the ovarian cancer. So likewise, we can approach if the case is given in the long case. And after coming to a diagnosis, usually we won't be having a differential diagnosis. We will be having the diagnosis. Then we have to take the proper history regarding the ovarian cancer, the associated symptom. Because I already told ovarian cancer may be a sex secreting tumor. So we have to ask about the sexual symptoms, how the sexual life is affected with these tumors, and the menstrual symptoms. Because menstrual cycles can be affected if there is a hormone secreting tumor. We can't make sure, just ask the question whether the menstrual cycle is over. So if the elderly patient where there is a postmenopausal bleeding, so if there's a younger patient, we have to take a proper menstrual history. How the menstruation was and how the menstruation is now. Just give the overall idea at the time of menarche and how is the cycles now, whether it's regular, irregular, what is the amount of bleeding, whether there is amenorrhea, kind of question we have to ask. And also just make sure that there is no features of hyperandrogenism. I already told there can be some tumors which can secrete androgen, which can cause the features of the masculinization, like voice change, the hardening of voice, hirsutism, and acne formation, and there is a baldness, there is a hair fall. Those features can be there if there is hyperandrogenism, but if that is so rare, just ask 1 or 2 questions and make sure that there are no features of androgenism, hyperandrogenism. And the bowel symptoms we have to ask because if the patient present with the abdominal distension, our differential diagnosis is bowel cancer. So at the time, you just ask some bowel symptoms and make sure that this is not a case. Just to make sure that this is to exclude the bowel differential diagnosis, not for our case. Just to exclude that. Just ask 1 or 2 questions and leave it there. So have you got it up to now?
Yes, Maja. Yeah.
Yes. Yeah. Then after finding confidently that this is a case of ovarian cancer, then we have to move out to this thing to find out the etiology and what are the protective factors and what has been done up to now. Those things we have to cover. For that, we have to know what are the risk factors for the ovarian cancer and what are the protective factors. We have to ask these factors. If you forget everything, no need to worry. Just ask at least 4 from each. But anyway, if you take the history properly, each and every segment, you would have covered everything. So no need to worry about that. So first we will look at the risk factors. Nulliparity is one of the risk factors. If the mother doesn't give the birth to the child, that's a risk factor. If the family history we know for each and every cancer, family history is risk factor. So family history is a risk factor. The thing is, I usually ask the risk factors and the protective factors here while getting the history of presenting complaint. If you need or if you like to ask in each separate segment that you are taking later, like family history, menstrual history, drug history, you can ask there also. That's your choice. You do, but you have been doing for the past time. No need to change now. Just I am telling here under the history of presenting complaint. Make sure that you are asking somewhere. If you ask, that's more than enough. And the infertility or subfertility. That is another risk factor. And the early menarche and the late menopause. So I want to tell what is happening here. Why all these features coming as a risk factor. If you take the pathology of the ovarian cancer, it is believed that whenever there's a trauma to the ovarian cancer, the risk of the ovarian when there's a trauma to the ovary, the risk of the ovarian tumor is increasing. So if you look at it, whenever there is increased number of menstrual cycle, there's a number of ovarian trauma is increasing. Why? Because whenever there's a menstruation, the ovarian tissue should be there and the ovum should come out and it should heal back. For the healing, it should proliferate. There should be a proliferation of tissue. So that is the trauma I'm talking here. The rupture of the ovary and releasing of ovum. That is the trauma I'm talking there. So if you take the nulliparity, infertility, early menarche, late menopause, these are the factors all lead to increased number of menstrual cycle. Alternatively, it increased the ovarian trauma. If you understand that, easy to remember. Nulliparity means there is no baby for the mother. So from the menarche up to the menopause, regularly she will be having the menstrual period. So the number of cycles is increasing. Same for the infertility. When we are giving, when the girl is giving the birth, for each birth around 9 months, she is absent from the menstrual cycle. So it is not happening in the infertility because she doesn't have baby. So the number of menstrual cycles is high. Early menarche and late menopause. The period from the early menarche and the menopause is increased. So the number of cycles anyway increased. So that is the reason these factors increase the risk of the ovarian cancer. Got it up to now? I just won't explain that.
Yes, madam. Yeah.
Then other one is a previous breast or endometrial cancer and the BRCA1, BRCA2 gene. The BRCA1, BRCA2 gene, just remember, if there is a family history of BRCA and BRCA1 or 2, or if the woman is having, there is a high risk of developing ovarian cancer. Not only the ovarian cancer, also breast cancer, ovarian cancer, endometrial cancer, and also the gastrointestinal cancer. BRCA1 for, I don't want to confuse, that's what I'm telling all for. Actually, BRCA1 for breast and ovarian cancer, and BRCA2 is for all four. No need to go up to that deep. Just remember BRCA1 and 2 altogether increase the risk for these 4 cancers: breast, endometrial, ovarian, and GAT. So these are the risk factors. Protective factor mean whatever the factors that reduce the number of menstrual cycle protect from the ovarian cancer. Oral contraceptive pill, breastfeeding, multiparity. Oral contraceptive pills stop the menstruation, so it reduces the menstrual cycle. Breastfeeding, when we do the proper breastfeeding, there will be absence of menstruation, so it reduces the menstrual cycle. And the multiparity mean multiple babies. So for each baby 10 months, so 3 babies means 30 months she will be absent from the menstruation. So all reduces the menstrual cycle. That lead to reduce the risk of ovarian cancer. So that are the risk. These are the risk factors and the protective factors. Okay, and the complication like other ovarian other malignancies, there are two kind of complication. One is due to the pressure effect. Due to the size of the ovary tumor, there can be some side effect. Some due to the malignancy itself. Pressure effect means it can compress the urinary tract, and it can produce a symptom of LUTs, lower urinary tract symptoms. You know the symptoms. Just ask those symptoms and make sure whether there are symptoms of LUTs or not. I already explained about the ankle edema or varicosity. Just ask about that. Nausea and vomiting, because at the time of the diagnosis, usually the ovarian tumors are so big. That is enough to compress on the diaphragm and push the stomach up. So it can cause nausea and vomitings more severely. And the shortness of breath, the same reason. So the lung, due to the compress of the diaphragm upwards, the lung capacity reduces. That can lead to the shortness of breath. Just make sure that you are asking these symptoms. And next, the symptom of malignancy itself. Due to the malignant ovarian tumor, there can be symptoms. Just go through the symptoms. This is same as other tumors, other cancers. Nothing new. So I'm not explaining in detail. Just go through the symptoms. Okay, up to now?
Yeah, Macha, yeah.
Okay. Then what has been done up to now? This is the important part that we have to tell at the end. What has been done up to now mean from the you have to give it in the sequential order. From the first day it has been diagnosed up to now. So from the first day of the presentation and up to now, you have to give it as a story. So what are the investigation done? If the patient know, what are the results of the investigation? And also at last, just tell during the current admission what has been done. Sometimes she might have done MRI, CT, ultrasound scan. Just mention that. If she knows the result, just mention that according to the patient, this is the result of the investigation. So if you finish up to now, that is a complete history of presenting complaint. No need to worry for anything. The investigation I will tell while I am discussing the management. So no need to worry. That's what I put the question, because explaining here regarding the investigation is somewhat difficult for me. So I will tell the investigation later. So what should be done in the case of ovarian tumor, I will explain later. So up to now, okay?
Yeah, Macha, yeah.
Okay. Then the continuation, the rest of the history, just make sure that you are covering this part. The thing is, they are giving separate marks for each component, path of history, path gene history. Even if you have gathered the information in the history of presenting complaint, just mention at least one sentence in each segment. Make sure that you are covering all the components. So if you make sure that, you will get the full marks. Okay, I think that's all for the history. Then we will move to the examination. Examination, I think you know the exam setting means. So we have done the exam setting. You will be given a time with the patient for the examination. We will be doing the examination with our supervisor, the examiners. But what you can do is, most of the students will be having enough time with the patient to take the history and examination. That is our general of examination setting. Everyone knows that. So you will be having enough time. After taking the history, you do the full examination of the patient, including the abdominal examination. Then you know what are you going to tell at the time of the examination with the examiners. So you won't be confused, because with that huge tension, if you do the examination first in front of the examiners, we will be totally confused, because we will be thinking of the tumor on the right side. Sometimes the tumor may be in the left side. So we will be confused. So just do the examination on the table with the patient when you are getting the history with the patient, and get an idea and go to the examiners. No one will be asking any questions when we are doing the examination. So just try to do that, because mostly you will be having a time. I had almost 1 hour with the patient, because there were a huge number of students as well. Anyway, you will be also getting at least 10 to 20 minutes extra with the patient to do the examination. So just do the examination, including the abdominal examination. That means my advice, if you can, just do it. If you can't, that is unluck, nothing to do. So general examination. So these are the important things you have to look at the general examination. Other thing, for the general examination to complete, you have to do the full general examination. These are the important things you have to look at it. Pale and icterate. So you know the reason, because due to the tumor itself, it can lead to pale. The females are high risk of anemia, so you have to look for the pale anyway. And the jaundice, it may be due to the metastasis to the liver. If there's just mention something about the pale and the jaundice. And the lymph node, we have to look for the lymph node, especially the inguinal lymph node. And also we can look for the abdominal lymph node if there is a metastasis. So just look for that. And general idea of the patient, whether the patient is wasted, well looking, ill looking. So just comment on that. And the last, ankle edema, bilateral ankle edema, is there or not. If there is varicose vein, just comment on that. So that is regarding the general examination. So other components, you may have to do that, but they will be looking at these components specifically. If they want to ask some question on the general examination, they will be asking this. Sometimes they may ask, what are the things you have got it from the general examination? Just tell the answer including this. And do the CVS RS if you have time. Mostly they won't be asking the findings of the CVS RS. So directly they will move to the abdominal examination. Usually what they ask is to do the gynecological abdominal examination. We have to do in a proper way. Usually they don't ask for the digital vaginal examination, but if you have unluck, sometimes they may give the gloves and ask to do at least the inspection. Some of our students, the previous exam has been given the digital vaginal examination also. That is unluck. Nothing can be done. So, but mostly they will be giving only the abdominal examination. We have to know the proper technique of the abdominal examination. That is again the inspection, palpation, percussion, and the auscultation. We have to go in order, but there is some kind of difference in the palpation. That is the most important thing they are looking at. We know we have to do the up to bottom, the vertical examination in a 3 line in the abdominal examination. I think everyone knows me. If this is abdomen, we have to go in this line. This is umbilicus. Everyone knows this name? Anyone have any confusion?
You have to like go in 3 lines, no?
Yeah, 3 lines from up to bottom, from chest region up to inguinal region.
Yeah.
If anyone have doubt, I will tell, because this is the most important thing they are looking at. This is not only for the ovarian examination, whatever the gynecological case, you have to do this abdominal examination. So you have to do in a proper way. So if anyone have any doubt, just ask me. Huh?
Okay.
Okay. Ne? So just do the examination and try to find out the mass. Whether there is, mostly there will be a mass. If you find out the mass, just look for the surface, the consistency, and look for the features and the nodularity, whether it's mobile in a vertical plane or horizontal plane, where there are multiple mass, and also look for others: hepatomegaly, splenomegaly, free fluid, renal mass, and auscultation. Sometimes they used to tell no need of auscultation. Auscultation is normal. And also we have to know the proper technique of doing eliciting the free fluid. They will ask. And here what we have to know is how to differentiate ovarian mass from the uterine mass. That is the common question to be asked in the case of ovarian or uterine case. We have to know that. Sometimes they may ask to elicit while doing examination. Sometimes they may ask in the question while the discussion. So how to do it? So what we have to do is first, when there are several techniques to differentiate ovarian mass from the uterine mass. In the palpation, the abdominal examination, there are techniques. Like when we are palpating the mass, we have to try to get below the lung. Like I'm explaining here. If you take the If we take this is a mass, we have to put the hand here and we have to try to go below the lump, and we have to look whether we can go below the lump. If we can go below the lump, usually that is an ovarian mass, because we know the uterine mass arising from the pelvic cavity, so we can't go below the lump. But the ovarian mass, when it grows, it comes into the abdominal cavity. So when we go below the lump, usually that is ovarian mass. This is usually. If we can't go below the lump, we can't say that this is uterine lump, because sometimes due to the huge size of the ovarian tumors also can extend from the abdominal cavity into the pelvic cavity. So we can't even go below the lump, though it is an ovarian tumor. So what we have to know is, if we can go below, usually that is ovarian tumor. But if we can't say whether it's a uterine or ovarian tumor. That is one. Then the mobility. Usually the ovarian tumor mobile in both plane, horizontal plane and the vertical plane. We can nicely move. But if you take the uterine tumor, we can't move in the vertical plane. That is impossible, because it is attached to the pelvic cavity. But we can move into the horizontal plane. This is possible. So if it moves in both plane, that is ovarian mass. If it doesn't move in the vertical plane but moves in the horizontal plane, that is uterine mass usually. Again, there's a problem, because ovarian mass sometimes malignancy can get attached to the adjacent structures. So sometimes even it can't move in both plane, or it can't move in the horizontal plane. So if it doesn't move, we can 100% sure that is whether it is ovarian mass or uterine mass. That is the problem with this one, the ovarian malignancy. So these are the two techniques that we can do while doing the abdominal examination. Is there any problem?
No, Macha, no.
Then we can. Okay. And also there's other two techniques with the digital vaginal examination. For that we have to do the bimanual examination. How to elicit, I will tell. So while doing the digital vaginal examination, we have to hold the mass from the abdomen. So like sorry. Like this is the abdomen. If there is a mass, we have to keep one hand here, like above the on the mass abdominally, and we have to do the digital vaginal examination, and we have to move the cervix with the fingers with the bimanual examination. With two fingers, we have to move it in the horizontally, and we have to see whether the mass is moving. If the mass is moving, then that is uterus. If it doesn't move, then that is the ovarian mass. Again, there's a problem. If the ovarian mass is attached to the uterus, then the ovarian mass also can move. That is a problem with the ovarian malignancy. So that you have to remember. Okay, these are the techniques that we have to elicit to differentiate the ovarian and the uterine mass in the examination setting, but nothing is 100%. We can get an idea only. Okay, if there's a problem, just ask me. Then the investigation, how to do the investigation, and I will tell the investigation. If this investigation has been done in the patients previously, just mention in the history of presenting complaint as I mentioned. Okay. The most important and the first investigation we have to do is transvaginal ultrasound scan with or without transabdominal ultrasound scan. That is a first line investigation we have to do in a ovarian malignancy, as I mentioned above. Whether there's a bilateral, whether there is a solid area, free fluid in the abdomen, whether there is hepatomegaly, and the ovarian tumors is a multilocular. Those are the features suggestive of the malignancy. And also I have given a chart. This is a iota classification of the ovarian tumor. And previously they were not asking regarding the iota, but for the last 2 years there have been questions regarding the iota classification, and they are asking the features of malignancy directly from the iota. So we have to know this. Unfortunately, just try to remember this. Just have an idea. This is unilocular and the cystic mass. But if there's a solid region or multilocular, that is malignant, towards malignancy. Free fluid hepatomegaly, again malignancy. Increased vascularity, again malignancy. And regarding the papillary kind of structure, they have shown these papillary structures. If there are 4 papillary structures or more, then malignancy. Less than that, then that is benign. These kind of features you have to know regarding the iota classification. Unfortunately, they are asking the question. So just before going the examination, just go through this classification. And the tumor markers. So when we will be doing the ultrasound scan abdomen, transvaginally and the transabdominally, and if we see ovarian tumor, then we will be doing the tumor marker. To do the tumor marker, we have to have an idea what kind of tumor can it be. Whether it can be an epithelial tumor or germ cell tumor. There the age plays its role. If the patient is an elderly patient, like a postmenopausal one or perimenopausal one, then we have to think about the epithelial tumor only. Mostly. Rarely they can have the germ cell tumor. Almost every time they will be having the epithelial tumor. So we have to only do CA1 to 5 in an elderly patient. Nothing else needed. But if the patient is a younger patient, like age of 25, 26, then it can be an epithelial tumor or it can be a germ cell tumor. So we have to do all this investigation, including epithelial tumor marker and others. So tumor markers I have already told. For the epithelial tumor, just remember CA1 to 5. We have to know that there are other tumor markers that should be done in a younger patient. So if you see a younger patient in the ward, you can see they would have done all this investigation. So that we have to know. Okay, ne?
Yeah, okay.
Then the other investigation, MRI, that is the far most important investigation in the ovarian tumor. In the to decide the proper management, MRI is the most important one, not the CECT. MRI is the MRI pelvis. But the problem is MRI pelvis is not available always. So we are also doing CECT abdomen and pelvis as well. But anyway, for the first time, at least once, we have to do the MRI to decide the mode of management. How to manage this ovarian tumor? We have to do the MRI. Without the MRI, we can't decide. For the follow-up, then we can continue with the CECT. At least the patient with ovarian tumor should have one MRI for the management. Okay? So these are the investigation usually the patient undergoes. Then we have to mention in the history of presenting complaint. I have taught here. Just add it there. Okay. This is other thing about the ovarian tumor. That RMI, you would have heard about that, risk of malignant index. And this is a calculation. With the calculation, we can have an idea whether the tumor is a malignant one or benign. Have an idea only, not we can't make sure, just we can have an idea. Risk of malignant index. This is used only for epithelial tumor. Because the RMI score includes CA1 to 5. U mean ultrasound scan score, M mean menopausal state, and the CA1 to 5. We have to multiply all three, and we have to get an number. Regarding the number, the amount, we can think whether this is a malignant or benign. We can have an idea only. We can make sure with this RMS score done for epithelial tumors only, because we are using only the CA 1 to 5. We can't use other tumor markers and use RMS score for other tumors, only for the epithelial tumor. This is also they will ask in the discussion, because for me they have asked to calculate the RMS score. Yeah, they have given everything, CA 1 to 5, M and U, and they asked to calculate, just to multiply that. We have to know, we have to multiply all three. Ultrasound scan, with the ultrasound scan scanning, we can have the score. M mean menopausal, whether it's a premenopausal or postmenopausal. For the premenopausal score is 1, postmenopausal score is 3. That is how we calculate. Sometimes they may ask, but I'm not sure they will ask. Most commonly they won't ask. So just have an idea on this. Then we will come to the management of all the ovarian tumor. Up to now, okay? Ne?
Yes, Maja. Okay.
Okay. Then the management. First, we will look at the management of the benign tumor. Benign tumor, that is here I am talking about the premenopausal one. Mean who has not attended the menopausal period. That kind of benign tumor, how are we going to manage the patient? If the size of the tumor is less than 5 centimeter, actually we don't require any further follow-up. We can just reassure the patient and discharge, because usually this kind of small tumors can resolve within 3 months. And 5 to 7 centimeter size of tumors, we have to do at least annual follow-up. We have to do the proper follow-up at least annually. But if we have a facility, we can't do 3 monthly, 6 monthly, we can do. But at least annual follow-up is needed. If the size is more then I will keep it here. Otherwise, okay. Then regarding the management, we will be first we will be look at the management of the benign ovarian tumors of the premenopausal woman. Okay. We will be looking at the management of benign ovarian tumors of the postmenopausal with the MCQ. Here we will be looking at benign ovarian tumors management for the premenopausal woman. So that is depend on the size of the tumor. That I have given all the details. If the size is less than 5 centimeter, actually we can reassure the patient and discharge. No need to do anything, because usually it spontaneously resolved. If the size is between 5 to 7 centimeters, we have to do the regular follow-up, at least annual follow-up. If we can go for 3 monthly, 6 monthly follow-up. If the size is more than 7 centimeters, we think that spontaneous resolution is unlikely. So we have to go for the excision of the cyst or tumor. So we are going for the laparoscopic rather than the open surgery. Why we don't do the aspiration is there is a high risk of recurrence. If you do the aspiration, it will recur. It's going okay. Well, name the sound.
Yeah, Maja. Yeah.
Okay. And all I have told, if the size is less than 5 centimeter, we can reassure and discharge. But the problem is, if we find at any cost, at any circumstances, if we find that the size of the tumor doesn't change, it remains at the same size, or the size is increasing for the last 1 year, for the 1 year of period, then we have to go for the excision. That is a different story. Even if the size is less than 5 centimeter, if the size is not changing, remaining at the same size, or if it's growing up, then we have to consider we have to go for the excision. That is the only exception. Okay, that is the management of benign tumor. So if you have any doubt, just ask, stop me and ask. Huh?
Okay,
Then
Macha.
this is the management of malignant tumor. This is the management, but we have to know for the management to tell the management in the long case. How to do the malignant with the RMS score or with the scan MRI, we would have find out malignant ovarian cyst. Then how are we going to approach the patient? We have to admit the patient and break the bad news. Breaking the bad news is far more important thing just mentioned in the long case. Break the bad news. After breaking the bad news, we have to do the multidisciplinary team meeting. That is very, very important. MDT meeting should be arranged. It should include gynecology, one gynecologist, or gynecology oncosurgeon, like our Kaniska sir, because he is a gyneco-oncosurgeon. So gynecology, gyneco-oncosurgeon, anesthetist, the responsible nursing officer, or vascular team member. So kind of this member should be included in the MDT meeting with the nutritionist, I think. Yeah, nutrition should always there. And they have to discuss how to approach the patient. With the investigation of MRI, they know with the MRI, the radiological findings, they know the extent of the tumor with the MRI. With that, they will decide whether we have to go for primary debulking or interval debulking. There are two things they can do, primary or interval debulking. They have to decide at the MDT meeting. Primary debulking means we are doing on the patient transabdominal hysterectomy, bisulfide oophorectomy, omentectomy, and the removal of deposit. Like what they mean primary debulking, we are opening the abdomen and we are removing the tumor with the uterus and the fallopian tube with ovary. And also we are removing whatever the deposits we see in the abdomen. That is the primary debulking. We can do in a patient who can tolerate that huge surgery, because this surgery needs a long period of time, like 7 hours, 8 hours. Some patient can't tolerate due to their condition, commonly the age population. For that people, we can go for the primary debulking. If the patient fit enough, then we can go for the primary debulking. At the same time, we have to make sure in the MDT meeting that we can remove all the deposit at the primary surgery. Then we can go for the primary debulking. That depend on the patient factor and the cancer tumor factors. So we will be doing the surgery, and after the surgery, we will be starting the adjuvant chemotherapy. Usually we are using the platinum based agent like cisplatin. So usually we can go for 6 cycles of chemotherapy. That is a recommended one. Maximum we can go for 6, because this is more toxic, the chemotherapy. So if you want to go for more than 6, that is so toxic for the patient. So maximum we can go for 6. So how we doing the 6 is, usually we give the 3 initially. After giving 3, we usually do a CECT and CA1 to 5 to see the successfulness of our chemotherapy. After seeing that result, only we are giving the other 3, only if needed. That is what we mean the primary debulking. We are opening the abdomen, doing the surgery and remove the deposit and come out and close the abdomen, and we are giving the chemotherapy. That is primary debulking. So you got it?
Yes, sir.
Yes, sir. Okay. Then interval debulking. Interval debulking is surgery where we can't do the primary debulking in a patient. We are going for interval debulking. The patient may be not fit enough. Sometimes even if we do the primary debulking, we can't remove all the deposits. Then we can't go for the primary debulking. The interval debulking mean, what's the problem? What's the thing is, we will be opening the abdomen, or we will approach the patient laparoscopically, and we will take a tissue for the as a biopsy. In the interval debulking, first we do that. We doing the laparotomy or we go for laparoscopically and remove the tissue and take a biopsy, small biopsy. And we confirm the diagnosis and we are giving the chemo. After giving the chemo of 3 cycles, we are going for surgery. That is interval debulking compared to the primary debulking. Because when we are giving the chemotherapy, it shrinks the malignant tissue. So after the shrinkage, we can go for the proper surgery. Why we have to do this biopsy thing before going for the chemotherapy? We have to have the proper histological diagnosis of the tumor. We have to make sure that this is ovarian malignancy histologically. Otherwise, we can't go for chemotherapy. That's what we are going and doing a biopsy, confirming the diagnosis, then going for the chemotherapy. That we have to know. Okay, ne?
Yeah, Maja.
These are the chemotherapy agents I have told. Then the management of germ cell tumor, you won't be getting this kind of patient in the for long case, but rarely they can give. So commonly there's epithelial tumor patients are given. So if there's a germ cell tumor, usually it occurs in a younger patient. So we can't go for the extensive TH and BSO because they may need babies. So what we are doing is we are using unilateral salpingo-oophorectomy and we are doing the adjuvant chemotherapy if the patient is fit enough. So, but if we can't do anything, then we have to go for the full surgery. Otherwise, if it's possible, then we will be doing this. That's depend on the stage of the tumor. We don't need to know that. Then the follow-up. Also mentioned this follow-up. This is how we usually follow up. 3 monthly in the first year, then 6 monthly, at least for 5 years. We have to do CA1 to 5 and ultrasound scan. Those are the follow-up method. Okay. Okay. Then the prevention. This is one important thing regarding the ovarian tumor. How to prevent? First, health education. I already told these are the protective factors: oral contraceptive pill, breastfeeding, and good perineal hygiene. If you do that, it can prevent from the development of the ovarian cancer. So those are the primary prevention methods. Surgically also we can prevent. How is this is done? If there's a family history, we have to investigate the person, the family members, the girls. If there's a positive for BRCA1 and 2, we can go for the surgical prevention by removing the bilateral tubes. Because why we are removing the tube? In the studies, we have got the information that the ovarian tumors arises from the fallopian tube. That is a recent study tells us. So we are removing the tubes, or we can go for the hysterectomy. That also prevents according to the study. We usually do that if we have the BRCA1, BRCA2 gene positive, because there is a high chance of development of cancer. So that is surgical prevention. That's all for the ovarian cancer. We can move to the question. So that's all. If anyone want to ask question, we have 15 minutes more.
Yeah, we can move on.
Move on. So these are the MCQ. I think I have shared the slides. Just look at the slides if you want later. So this is 38-year-old lady was diagnosed with unilocular cyst in the left ovary. So 38 means premenopausal. Unilocular means there is a one cyst in the left ovary. On ultrasound scan, the size is 6 to 5 centimeter and no solid areas. All tells it towards a benign one. Premenopausal one, unilocular, and no solid areas. Uterus and the right ovary are normal, no free fluid. CA1 to 5 is 130. So that is very, very less. What is the most important next step? So we know this is a benign tumor. The size is 6 to 5 centimeter. So no need to do anything abruptly. We can wait and watch. So we can follow up the patient with ultrasound scan. No need of going for CCT. Laparoscopic cystectomy is needed if the size is more than 7 centimeter. So no need to do that now. Aspiration, anyway, I told we are not doing the aspiration because of the recurrence risk. So the answer is A, follow-up with ultrasound scan in 3 months. We can do in 3 months or 6 months or annually at least. So if there is any doubt, ask me regarding the first question.
Oh, it's fine.
Fine. The second one is a 53-year-old postmenopausal woman. This is regarding the postmenopausal. Menopausal is stopped. Woman with a CA125 level of again 13. Ultrasound scan suggests 4 centimeter size. Again unilocular ovarian cyst in left ovary. The problem is this is postmenopausal one and the size is 4 centimeter. That anyway it is unilocular. That is towards a benign one. She is asymptomatic, cyst persisted in the same size for 1 year duration. What would be the best management option for her? The thing is, there's one thing you have to know. Whatever that they tell 4 centimeter size, that is persisting for 1 year duration. That's what I told earlier. Whatever the size, it has to be resolved within 3 months. If you are watching, if you want to reassure the patient, but here they have told, though the symptoms are towards benign and asymptomatic, the cyst is persisting for more than 1 year duration. So what we can do, this is a benign condition, so this is persisting, then we can go for the removal of the tumor. And after removing, we can send it for the biopsy and we can have a look whether it's whether that is benign or malignant. So we can go for the laparoscopic cystectomy. No need to do the TEH and BSO because this is totally a benign one, according to the question. Reassure and discharge we can't do because that is persisting for 1 year duration. Repeat the investigation in 6 months? No, because it has been already persisted for more than 1 year. Laparoscopic cystectomy, we can do, that is thing we have to do. Aspiration is can't be done. Any question?
Thank you.
So if you have time, just have a look at it. This is how to approach a patient with a tumor, ovarian tumor or cyst in a post-menopausal woman. No need to remind everything, just have a look at it. That's why I have given the slide. This is from the RCOG guideline. So the next question, 45-year-old lady presented with the abdominal mass. So what is the clinical feature that is more suggestive of a fibroid rather than the endometrioma? This is a SBR question. So what they are asking is, what is the features tells more that this is fibroid, not an endometrioma. Endometrioma means we know that chocolate cyst of the ovary due to the endometriosis. So we will be looking at it. Absence of ascites. So both conditions are benign conditions. Absence of ascites won't be there. Sometimes it may be there in the endometrioma, not in the fibroid. Fibroid is a totally benign condition. So that is a false. Smooth surface. Usually both fibroid and endometrioma smooth surface. Fibroid can be, multiple fibroid can be lobulated one. The surface is always smooth. So that is also false. Firm consistency, yes, that is true. Fibroid is always a firm one towards a solid one, kind of solid mass. Endometrioma is a cystic mass. So that is true. Limited vertical movement. Yes, fibroid arises from the uterus. So the vertical movement is reduced. But here the case is endometrioma. Endometrioma is endometriosis. So in the endometriosis, we usually see huge adhesions. So the endometrioma usually adhere to the uterus. So even the endometrioma can have limited vertical movement. That is a tricky point. Sometimes we may directly see, so limited vertical movements is only for fibroid, not for the endometrioma. But that's what I explained, that even in the inflammatory conditions like this and the malignant condition, vertical movement can be limited, even in the ovarian tumor. So that is false. The same for the answer E, mobility with the cervix. Endometrioma can even have the reduced mobility with the cervix if it's attached to the this one. Okay, the answer is firm consistency. If you have any doubt or question, ask me. This is my answers. Sometimes there may be some mistakes. Okay.
Okay, Macha. Sure.
Okay. Okay, the next one, the 30-year-old lady, the premenopausal woman has a family history of ovarian cancer. What is the most appropriate test to predict the probability of developing ovarian cancer? So just look at the answer, annual ultrasound scan. There is no system in anywhere to do the annual ultrasound scan to find the ovarian cancer. So that is false. Regular CA125, no, we can't do that because we do CA125 if we suspect the ovarian cancer only. To predict the ovarian cancer, we can't do. But I already told BRCA1, BRCA2 is the most important one because even if the patient is having BRCA1, BRCA2, after the complement of the family, we are going for the prophylactic removal of tubes and the uterus as a preventive measure. So that is true. Diagnostic laparoscopy we are not doing. We don't see any patients going diagnostic laparoscopy as a predictive value, and annual Doppler we are not doing. So the answer is BRCA1, BRCA2. If the family member having BRCA1, BRCA2, there is a high risk of development of ovarian cancer. So the answer is C. The next one, 51-year-old woman, almost postmenopausal, presented with a bilocular ovarian cyst. There's a two locules, two surface of the left side. Left side measuring 67 centimeter in size. No solid components were seen. A small amount of fluid was seen in the pouch of Douglas. The right side ovary and the uterus appears normal. What is the most appropriate next step in the management? So this is almost postmenopausal woman, and there's a bilocular ovarian cyst. The size is also large, though there is no solid component, but there is some amount of fluid in the pouch of Douglas. Not ascitic, but still there's a fluid. So we should not miss the ovarian malignancy. So we have to further investigate this case. Case-wise approach. So we have to investigate further. So what is the next investigation? We have to do CA125. Because here we are suspecting a epithelial tumor. We have to do tumor marker for epithelial tumor because this is a postmenopausal woman. So we have to do a CA125. Review in 6 months. We can't wait because there are some features suggestive of malignancy. Ovarian cystectomy we can't do because we have to investigate further, because we have some kind of investigation method to investigate further. Aspiration anyway false. CCD abdomen only after CA125 level. So the answer is CA125 level. Okay. Any question ask me? I am moving. Epithelial tumors, ovarian tumors include. This is completely theory one. I also don't remember. It has been given in our lectures as well. Just I am giving the answer and that notes. These are the epithelial tumors. They are. Just remember, we can't do anything. This kind of question has been asked. So there are. I have given 5 tumors. So just keep in mind. So then next question is risk factors for ovarian cancer include. So we have already studied that. So what are the risk factors? Combined oral contraceptive pill we have studied, that is a protective factor, that is false. Hysterectomy, that is not a risk factor, that is false. Nulliparity years, again, that is true, that is a risk factor. Presence of BRCA1 gene, that is true. And the problem with the tamoxifen, I have taken it as true because this is again selective estrogen receptor modulator. So it can still stimulate ovary because it is used as a ovulation for the ovulation induction. But I am not 100% sure about the answer.
True name, because with long-term tamoxifen, endometrial cancers also get increased, no? So
increase. I think that will be true, then.
And the ovarian also there is a hormonal component, no?
Yeah. No, the problem is whenever there is an increment of the ovulation cycles, the risk is increased. The tamoxifen doesn't cause the hyperstimulation. That is the one problem.
Yeah,
Clomiphene citrate actually increase the risk of ovarian cancer. There is no doubt.
tamoxifen then it modulates estrogen, so it's gives some amount of. I know that it increases endometrial cancers.
Yeah, in endometrial cancer, that is 100% is true because that gives the estrogen. Estrogen proliferate the endometrial tissue. So that is correct for the endometrial.
So
The
if
problem
estrogen is high, the ovarian cycles should become irregular, no?
yeah, that is a problem. Just if you have any kind of questions, just ask please. Just leave it there. But anyway, I will confirm with someone.
Okay.
I don't know whether I have confirmed it. I marked it, but I have also have some doubt. If the answer is clomiphene citrate, that is true because clomiphene citrate cause hyperstimulation of the ovary. So even if we go for more than 12 cycles of clomiphene citrate, that is high risk for the ovarian cancer. We usually don't do more than 12 cycles. Maximum 6 cycles we are doing.
Yeah.
With the tamoxifen, the problem is it doesn't go the hyperstimulation syndrome. So I will anyway make sure and let it know.
Okay, madam.
Others answer okay.
Yeah.
Okay. Ultrasound scan features of the malignant ovarian tumor. I will give just the answer. That is, the answers all are there in my slides. That IOTA classification. So just go through that. That's what I told you. Just remember the IOTA. For the last year, they have been asking at least one questions per year on the IOTA classification. Someday you also may have one question. That's all regarding that. The SEQ is very rare, but if you study this, you can answer the SEQ as well. I think for the proper paper, we had one SEQ regarding the ovarian cancer.
I don't remember.
Okay. No need, but this is an easy topic. Don't take it as a difficult one because ovarian tumor, doing a long case is very, very easy. That's what I have felt. The details are very, very less, and the patients will be telling the huge number of stories, so we can nicely present the history. Even the examiners know that these are the common, these kind of idiotic presentation is common. So we can nicely tell whatever the story we need. So we can nicely do you guys can do. So just study the theory and prepare for the case.
Okay, Macha. Thank you.
If anyone have any doubt, just ask me. Okay, you can even message me.
Thank you.
Okay, Macha.
Thank you. Bye.
Thank you.